Good morning, everyone. Welcome to day 2 of the 10th Annual Cell and Gene Therapy 2025 Symposium. We'll begin with the cell therapy for hematological disorder, our first session. Please welcome our session chairs, Dr. Everett Nelson, Professor, School of Bioscience and Technology, Vellore Institute of Technology, Vellore. Dr. Poongurli, Professor, Department of Hematology, Christian Medical College, Vellore.
We begin the session now. It's my privilege to welcome Dr. Biju George as the first speaker of this session. He's a clinician scientist specializing in hematology, particularly in the management of bone marrow failure disorders and stem cell transplantation. He's trained at CMC Vellore under Dr. Maman Chandy and has developed standardized protocol for infections post-transplant, conditioning regimens for aplastic anemia, and strategies to prevent graft versus host disease. His work includes specialized transplantation approaches for congenital disorders such as Fanconi anemia and ongoing multicenter clinical trials in India. Today he will talk on looking beyond matched sibling donor transplant for hematological malignancies. Over to you, Dr.
Thank you, and I'd like to start by thanking Dr. Nihal and the rest of the organizing team for inviting me for this symposium. So what I'm going to do the next 25 minutes is to look at what can we do beyond matched sibling donor transplant. Now, allogenic transplant is probably one of the best curative forms of therapy that are available for hematological malignancies. Of course, for each disease, there are specific indications where a transplant would be performed. And in India, unlike the West, a number of transplants are performed for benign hematological disorders. So we started the transplant program in 1986, and this is data till about June 2025. We have completed about 3,800 transplants, and if you look, about 50% are benign, that is thalassemia and aplastic anemia, and that just sort of reflects the burden of disease we have in our population. But roughly about 40%, this is AML, ALL, and chronic myeloid leukemia, are the three major hematological malignancies that we do transplants for. So in this, I will just focus on malignant disorders and not on the benign diseases. Unfortunately, when we look at matched sibling donor transplants, roughly about only 30% will have a matched sibling donor in the family, and that is based upon how HLA is inherited from your parents. But if you do have a matched sibling donor, then what are the outcomes? So this was a publication by Vikram about 8 years back looking at AML and a strategy for India. We looked at about 254 patients and essentially showed that overall roughly about 50% are cured, with patients who are in remission doing far better than patients who are not in remission, and importantly showing that a reduced intensity transplant did far better as compared to myeloablative transplant. And there are many factors for it, including the fact that a lot of them have coexisting infections. With ALL, it was roughly about 44%. Now, there are specific indications, like I mentioned, with pH positive ALL, early thymic precursor ALLs, primary induction failure. Importantly, compared to the West, the use of drugs like blinatumomab and inotuzumab are actually very, very limited because of the cost that is involved. So this was about 339 transplants done for ALL, of which the matched siblings were 182 and roughly about 44%. Now these data is sort of similar to what we get from either the CIBMT or on the EBMT, where we are looking at about 45 to 50% chance of cure with the allogenic transplant. But what are the options if a matched sibling donor is not available? And there are two major groups that we look at. One, what is called as a matched unrelated donor transplant, and two is a haploidentical stem cell transplant. The match, one of the important things to remember in India is the fact that we cater to a large population of different socioeconomic strata, ranging from the very poor to the middle class to the upper class, and we have to make sure that we provide solutions for all patients of all classes. So for a matched unrelated donor transplant, one of the suppositions is that 1 in a million people around the world will have the same HLA as you, and that's because the number of HLA haplotypes that are present are sort of restricted within the human population. And so there are multiple bone marrow transplant registries that are available around the world. Within India, we have 3 of them. There's the DA3, there's the MDRI in Bombay, and there's the DKMS BMST, which is there in Bangalore. So we do the HLA typing, and then this is sent forward to these registries to look for a donor. These registries have their own drives in which they would get people to come and do their HLA typing. Generally, it is a buccal swab. These are different registries around the world. Right at the bottom is the DA3 from Chennai. And they collect this data, and this is stored on their computers. So if we do find a donor somewhere, then we can proceed with a transplant. So what happens is that the patient remains here in CMC while the donor is actually harvested wherever they are. So if the donor is in Canada, the donor actually gets a workup done and harvested in Canada. The times are synchronized so that there is no wastage. Generally, we start conditioning here. They will start the collection of the cells there, and then they usually book 2-3 different flights to 2-3 different routes so that the product arrives in time here, and then you can do a transplant. So one of the problems for India is the fact that the Indian population is very underrepresented in many of the major registries, and some time back when we looked at the number of searches, roughly in about only 15% do we find a donor. But where do we find the donor? This is in the German registry, the Indian registry, and the NMDP, where we can find donors. So this is data. So we have done so far about 400 transplants of matched unrelated donor, of which about 241 have been done for malignant diseases, and this has been steadily progressing over the years. We've got donors from the DA3 and the DKMS mainly, and a few from the NMTP. And the major indications, as you see at the bottom, are acute myeloid leukemia and acute lymphoblastic leukemia. And roughly about 50% of the donors are fully matched 10 by 10, but about half of them are less than 10 by 10. Usually we accept a 9 by 10 donor for a leukemia transplant. Engraftment is seen in about 85%, acute GVHD in 42%, and chronic GVHD about 48%, relapse in 23%, with an overall survival about 45%. So when we break this down, and this is the overall survival for MUDs in acute lymphoblastic leukemia, it is roughly about 45%, and if you look on the right, this is the CIBMTR figures on matched unrelated donor transplants for ALL. It is roughly about 45 to 50%, so it's almost similar in both groups. Even in the matched unrelated donor transplants, it's about 50%, and roughly about 55 to 60% with the CIBMTR data. But over the years, it's been improving. When we did an analysis which was roughly about 5 to 7 years back, our outcomes with MUD were only about 37%, so definitely over a period of years has been improving. Our major problems have been transplant-related mortality, mainly due to graft versus host disease and sepsis, and of course relapses that occur. But there are limitations of doing a MUD transplant in India. And the limitations are that one is the availability of the donor. Like we said, in only about 15 to 20% would you actually find a donor that is compatible for you to use for the transplant. Then of course the cost. Unlike a matched sibling donor transplant where the cost is about 15 lakhs, for a MUD it is about 25 lakhs, plus there is an additional cost of the registry. So whichever registry you procure these cells from, you need to pay a cost. If you have the Indian registry or if you have the German registry, they charge about 8 lakhs. If it's the US registry, they charge actually a large amount of 45 lakhs just for the product alone. So many times the use of a MUD transplant is limited because of the cost that is involved. The third is from the time you initiate a search to actually performing the transplant, it can take between 2 to 4 months. And that is the time that is generally involved. Now that becomes a problem when you have things like high-risk leukemia, where you cannot afford to wait for many months to do a transplant because there is a good chance that the disease will relapse back. So that is always one of the problems with a mud transplant. And unfortunately, if the patient relapses, or if you want to do donor lymphocyte infusion for immunotherapy, sometimes you may not have the donor available. So these are all some of the limitations that occur with the matched unrelated donor transplant, and that is where the whole idea of a haploidentical transplant is catching up. Now, what are the advantages is immediate donor availability. So for example, for a child, both parents are haploidentical, so they serve as donors. For an older patient, you can either have parents or siblings or children who will be haploidentical. So the data is that roughly about 90, probably even 95% of patients who need a transplant will find a haploidentical donor somewhere among the 3 generations that are available. The other important things is that because it's within the family, the turnaround time is very quick. You don't have to wait for 2, 3, 4 months. The donor is available for a second graft if required, and the donor is available for donor lymphocyte infusion or immunotherapy. Now, we started the sibling donor transplants in 86. We actually did a few haploidentical transplants using selection between 2003 to 2010, which was the CD34 positive selection. But that did not go too well. We had a lot of viral infections and we had major mortality, so we actually stopped the program. In 2011, there was publications which came out from Johns Hopkins suggesting that instead of doing the selection, we could use a cheap drug like post-transplant cyclophosphamide to reduce the risk of graft versus host disease and graft failure. And subsequently, we started the haploidentical program in 2011. So far, we have done about 630 haploidentical transplants, of which 383 have been done for malignant disease. So over a period of time, the number of transplants we've been doing have been gradually increasing, and this is not just here. All over India, the number of haploidentical transplants have actually been going up rapidly, mainly because of the fact that you have an easy access to a donor immediately within the family. So when we look at what are the indications for haploidentical transplants, roughly about 50% are malignancies, so AML and ALL, and of course there are smaller numbers like CML and primary myelofibrosis, and then there is of course bone marrow failure syndromes and primary immunodeficiencies, which are some of the other indications for haploidentical transplant. So I'm going to just be talking about haploidentical transplants and malignancies. So we have done about 383 patients, and this is the number of patients which have been in different groups, focusing mainly on acute myeloid leukemia and acute lymphoblastic leukemia, but non-Hodgkin's lymphoma and Hodgkin's disease, CML, myelodysplastic syndrome, myelofibrosis, CLL. There have been some of the other indications where we have used haploidentical transplant. Now, the conditioning can be either myeloablative or reduced intensity, and we use myeloablative in about 48%. Initial few transplants, we used a bone marrow as was described by Johns Hopkins. Unfortunately, engraftment is slow. When engraftment is slow, there is a high risk of gram-negative infections, and you know that in India, we deal with the problem of multi-drug resistant GNBs, and so we switched over to peripheral blood stem cells so that we have a very fast engraftment that occurs. Engraftment is seen in about 90%, acute graft versus host disease in 42%, chronic graft versus host disease in 39%, and roughly about a 45% survival, which is actually similar to what you would see with the mud transplants. Now, over the years, of course, it's been improving. So when we started off, it was a learning curve. So roughly only about 30% survived within the first 5 years of transplant. Subsequently, it went up to 40%, and now we are sitting at about 53% during the last 5 years. So what happens when you look at specific diseases? From AML, we are looking at about a 50% 2-year overall survival. And this is actually very similar if you look at the right to CR1 and CR2 in AML. This is from the CIBMTR data. So we are doing reasonably well. It is about 46% with ALL. Unfortunately, this is lower than what is described in the CIBMTR, which is roughly about 60%. So we are about 10-15% lower in terms of our survival. And so we needed to look at measures to see how we can improve outcomes. So earlier we were using conditioning, which consists of either chemotherapy alone. And so we decided to see whether we could change over to TBI or irradiation-based conditioning. Now, in irradiation-based conditioning, what is new is something called as total marrow lymphoid irradiation instead of total body irradiation. And we worked with our colleagues in radiation oncology, Dr. Selvamani and Dr. Rajesh, to actually establish total marrow lymphoid irradiation for ALL in our institution. Now, why TMLI? TMLI is important because it spares a lot of organs which get hit when you use total body irradiation. The lungs, hearts, kidneys, the eyes, the oral cavity, and the parotid. So it significantly reduces the dose to the organs at risk, and that also helps us in doing dose escalation studies if we do need to do it. And so if you look at some of the studies that were done, if this is the dose that is given when you have TBI and this is TMLI, you have between a 20 to 40% reduction in doses which go to these organs which are critical for the human body but not critical for bone marrow transplant. So you are able to reduce the dose to these organisms, which means you end up reducing toxicity, and if you end up reducing toxicity, mortality should come down. So we devised specific studies which we did after getting IRB approval for both haploidentical and for mud transplants. And we had published initially about 20 patients who had TMLI, which showed very good results. And then subsequently we looked at data in haploidentical transplants and matched sibling donor transplants with standard conditioning. And importantly, the haploidentical platform, while we were looking at about 30% with chemotherapy-based conditioning, we actually could push it up to almost 60 to 70% with the use of a total marrow lymphoid irradiation conditioning. Now, this is early data, so we do not know, as we see these patients down a period of time, whether you are going to have more relapses that occur. That is something we need to watch out for, but at least in terms of early mortality and the ease with which they go through a transplant, it is probably better. We still have a lot of teething problems, including problems with veno-occlusive disease, because we are doing myeloablative, and that is something we need to look at. The other group was the AML group, so we were using either myeloablative or reduced intensity conditioning. In the whole group, the graft failure was less than 5%, with about 40% acute GVHD, 24% relapse rates. But importantly, in the older people, they were not doing so well. There was more GVHD, there was more relapse mortality, and the question was, can we do something better for that group? Because if you remember, AML is a disease actually of the elderly. The median age group is about 50 to 55. So a lot of patients who would go for transplant would belong to the older age group. And so we needed to find out something which we can do to help in reducing mortality. So one of the advances in technology which has helped us is this whole process of what is called as alpha beta depleted transplants. Now within the bone marrow harvest that you have your CD34 cells, which are your stem cells which you need for transplants. You have activated T cells, which are the ones which cause graft versus host disease. You have memory T cells, which are useful for immune reconstitution. So you can actually pass this through a machine, separate out all the T cells, remove out the alpha beta T cells which cause graft versus host disease, keep the memory T cells which can be given as a add back. So you have a very pure product of more than 95% cells which are only CD34. When we previously did this with CD34 selection, because T cells were not being added back, immune reconstitution was poor, and so because of that they had much higher toxicity and viral infections. So we use a reduced intensity conditioning protocol. Because there is also B cell depletion, we use rituximab to prevent EBV reactivation. We give a whopping cell dose of 10 to 15 CD34s. We make sure that alpha beta is depleted very well, and importantly there is no other GVHD prophylaxis that is given unless the alpha beta doses are very high. That helps in reducing the toxicity. Remember, once you go above 40-45 years, they have other comorbidities. When they have comorbidities, they may have underlying renal dysfunction, hypertension, and that when you add on calcineurin inhibitors as graft versus host disease prophylaxis, then you end up getting more problems that can occur. So right now, and this is data from my colleague Dr. Uday, we have done, in this age group of above 40, we have done about 16 patients at a median age of 58 years, ranging from 40 to 71, including AML, MDS, MPN, and MPAL, mainly flu-MEL TBI and flu-trio with one with BU, so both myeloablative and non-myeloablative. We used a median cell dose of 12, and importantly, we got very low alpha beta doses. This means that the depletion kit is working very well, and we are able to deplete a lot of the products, and we've got good gamma delta cell dose. I just wanted to mention one more thing, is that what we do subsequently down the line is to give T cell boosts at day 30, 60, 90 to help in immune reconstitution. So unlike the standard haploidentical transplant where the median time to engraftment is about 17 days, here engraftment was seen in about 10 days, and that's because you're not giving any GVHD prophylaxis, you're putting in a large boost of CD34 cells, so you get a much higher and faster engraftment. Platelet engraftment was 14. We had low levels of graft failure. Acute GVHD is still about 40%, chronic GVHD 25%, and importantly, survival was better at roughly about 60%. So we compared it with a cohort of patients who were above the age of 40 where we used PTCY, and there the overall survival was only about 30%. So definitely in the older patients, using an alpha beta T cell depleted transplant is useful. Unfortunately, there is a cost involved. So the depletion kit with the antibodies adds another 15 lakhs to the cost of the transplant. So this is actually similar to the cost of a mud transplant, but still out of a reach of a large number of patients. So I'll stop by saying alternate donor transplants is increasingly be used in India more than mud. Survival seems to be similar in both types of transplants. The use of a TMLI based conditioning has improved outcomes of haploidentical transplants in ALL, and the use of alpha beta depleted transplants has helped improving outcomes in older adults with AML and MDS. We still have a long way to go to improve the outcomes, but we think in the next 5 years we can get close to, I would look at close to 70% chances of survival in both these groups with alternate donor transplants. Thank you for your attention, and I'll be happy to take questions if any.
Refurbishing my knowledge from 30 years ago. So just a question on gonadotoxicity. You've shifted, you said you talked about cyclophosphamide after the transplant. and you're still doing that. Have you noticed an increased frequency of gonadotrophy by giving that cyclophosphamide post-transplant? Second is your switch from total body irradiation to total lymphoid radiation, but there's still a risk of gonadotrophy. So are you selective in terms of the age group you're going to be using it, etc.? Of course, I know AML and all is like heavy life-threatening stuff, but yeah.
So I would say two things. One, that the use of post-transplant cyclophosphamide is relatively new, so we do not know too much about gonadal toxicity, and it's in the adults. But I would look at it, we are also using PTCY in the aplastic anemia group, and there again we do not see much gonadal toxicity. We have had enough patients who have gone through a PTCI based transplant and then have had children down the line, so we do not see that too much. But in terms of the haplo, we need to have a look. There is also pediatric cohort whom we are following up, but we need a much longer follow-up to see that. Now, in terms of your total marrow lymphoid irradiation, the amount of radiation that is going to the gonads is actually less as compared to total body radiation, or when we were doing the chemotherapy base where we were using busulfan at high doses, which is again much more which has more gonadal toxicity. So again there we need to see a longer follow-up for these patients, but I would assume that gonadal toxicity will still be lower, may not be zero, but definitely will be lower.
So you are depleting the alpha beta T cells to reduce the risk of graft versus host disease. But you also mentioned that the alpha beta T cells are supplemented later to enhance the reconstitution. So don't you think that is this from the same donor?
So there are two things that we do. So when we get the product, about 80% is kept for the alpha beta depletion, and rest 20% is kept to prepare the cells so that we can do T cell add back later. So it's from the same harvest. And we have a specific dose that we give at day 30, 60 and 90 based upon whether the patient is already, our worry again is will you develop graft versus host disease. Yeah. So we keep a watch to see whether they have developed clinical graft versus host disease before we actually give these cells back. So in some patients who already have developed GVHD, we may not give cells back at all.
Okay, thank you.